Hi everyone, my name is Irvin Ng, and I'm a graduate student at the University of British Columbia located in Vancouver, Canada. Today, I'll be talking about predicting sustained remission and maximal disease severity in pediatric Crohn's disease using machine learning. To start off, pediatric Crohn's disease is characterized by inflammation of the gastrointestinal tract. Disease progression is highly heterogeneous, where some children, they get diagnosed, they undergo treatment, and they sustain remission. But a very large population of children have recurring flare-ups or they have very severe disease. Now, studies show that earlier aggressive intervention for these high-risk patients lead to better clinical outcomes. But currently, clinicians rely heavily on subjective clinical judgment and experience rather than data-driven approaches to do risk stratification and to guide disease management. And so the question is, can we leverage machine learning to predict who's at risk of these more severe disease trajectories? And so we developed machine learning models to predict two different first-year clinical outcomes. Specifically, whether a patient will achieve sustained remission or have non-sustained remission in the first year. We're also predicting peak disease severity post-diagnosis. Specifically, after diagnosis, we're predicting whether patients at their most severe disease state have mild disease or severe disease. And the significance is straightforward. Earlier identification of high-risk patients enables earlier treatment escalation and better outcomes for children. And so we generated 3 separate datasets using 86 pediatric Crohn's disease patients, where one dataset contained microbiome profiles, another dataset contained clinical variables, and a third integrated dataset combined both microbiome and clinical data. We trained 9 different machine learning models on each of these datasets to predict sustained remission and maximal disease severity. To ensure robust model performance, we implemented repeated nested k-fold cross-validation, where the inner loop conducted and optimized feature selection and hyperparameter tuning, while the outer loop provided unbiased performance estimates on held-out test data. We compared model performance using AURLC, and then to enhance clinical interpretability, we applied SHAP values to explain which features were driving predictions. Finally, to evaluate the clinical utility of our models, we performed Bayesian decision curve analysis, which quantifies the net benefit of using the model to guide clinical decisions across different probability thresholds. Now, looking at sustained remission prediction, the integrated logistic regression model achieved the best performance with a mean AURLC of 0.763, showing that combining microbiome and clinical data improves prediction performance, likely due to complementary signals. Looking at the top informative features, we see that features like disease location and Eubacterium elegans predicted remission, with prior studies actually showing that Eubacterium elegans promotes anti-inflammatory activity. On the other hand, initial therapy and hemophilus predicted non-sustained remission. Finally, the Bayesian decision curve analysis shows that our integrated logistic regression model has clinical utility, as the posterior probability that the model-guided decisions outperform treat-all or treat-none strategies peak at around 25%, and this aligns closely with the decision threshold where clinicians would typically intervene in clinical practice. So this suggests that our model is well calibrated to real-world clinical decision-making. For maximal disease severity prediction, we again evaluated the 9 algorithms across the 3 different data modalities. Interestingly, the microbiome alone Gaussian-naive based model achieved the best performance with a mean AURLC of 0.801. And this suggests that the microbiome composition alone provides strong predictive signal for disease severity trajectories. SHAP analysis of this model revealed distinct microbial signatures associated with disease severity. Clostridium was the strongest predictor of more severe disease, and this aligns with its known pro-inflammatory role in gut dysbiosis. Conversely, beneficial microbes like Coprococcus and Rhodopsia predicted milder disease activity. These were short-chain fatty acid producers associated with gut health and anti-inflammatory effects. The Bayesian decision curve analysis once again shows that our microbiome Gaussian-naive based model has clinical utility, with the posterior probability peaking near the clinician-determined threshold. Once again, this indicates that the model could provide meaningful clinical benefit for identifying patients at risk of severe disease trajectory. So what does this all mean? Well, expandable models can address 2 critical prognostic challenges in pediatric Crohn's disease: distinguishing sustained from non-sustained remission and identifying disease severity. Second, integrating microbiome and clinical data demonstrated superior predictive value for remission prediction, while the microbiome alone may be an early indicator of disease severity, suggesting that different data modalities matter for different outcomes. Our best models outperform different treatment strategies within clinically relevant decision thresholds. And so ultimately, our work opens the door to more personalized data-driven approaches to pediatric Crohn's disease management. Thank you.